Hello. Good evening.
Sir, we are beginning the
Dr.
session
Mahesh,
now.
we are starting now. Yeah, we can start.
Yes, Nishant, you can start now.
Okay, thank you, Supriya. So, good evening, doctors. We welcome you on the behalf of Shockwave Medical and Translumina to Shock the Rock session. And just a small introduction about Translumina and the current updates of our cardiovascular portfolio. I'm sharing my screen. So, Translumina today is a leading manufacturer and the distributor of the interventional cardiology and the vascular devices in India, with an extensive network coverage of more than 1,200 cath labs and a coverage of more than 2,000 physicians. We have a strong network of 120 channel partners with a coverage with our more than 100 plus sales team members covering them. We have a well diversified portfolio which provides solution across the cath labs in the cardiovascular portfolio, and with the support of all our doctors, uh, as per NIC 2026 data, I am pleased to share that Translumina is the second largest stent player and domestic leader in this in India. And our journey doesn't stop here in India. We have a strong global presence with a strong uh, partnerships with the like a portfolio of Shockwave IVL, OPN, NC, Nick Nano, as well as drug-eluting stent, which is the latest one. US FDA is the Medinol. We have the 5 manufacturing facilities spanning from 3 in India, 1 in Germany, and 1 in Netherlands. If I talk, if I talk about our diverse product portfolio, we have the solution-oriented approach from accessing the lesion to treating the lesion. We have in access portfolio Asai guide wires, Kaneka microcatheters. In SS, we have the imaging portfolio on strong partnership with Assist HDI and Assist CVI with options soon we are going to launch in the market. In the prepared portfolio, we have a strong partnership with the leading calcium modification company globally, which is Shockwave Medical, and we have all 4 catheters present in India: Shockwave C2, C2 Plus, M5 Plus, and S4. And now we are going to upcoming generation of catheter is Shockwave Arrow very soon. Sys Medical, OPN NC, Kaneka, and Optima NC. And in the treat portfolio, we have our own drug-eluting stunts, Yukon series, Vivo ISAR Summit, and the new stunt we have launched is the Alunir Pearl, the collaboration with Madinol. So Translumina has always believed in the innovation, in the providing solution across the cardiovascular segment. And with this solution providing, we are hosting this Shock the Rock symposium in calcium modification with our international faculty, Dr. Sandeep Basavaraj. And Dr. Sandeep Basavaraj is a consultant interventional cardiologist at University Hospital Birmingham, UK, and with wide and extensive experience in managing complex cases. Sir is founder of the CTO PCI program at Heartlands Hospital, now a leading center in the region, with specialization in complex CTO cases with both antegrade and retrograde approaches, and completed successfully more than 800 CTO cases. A regular international faculty and multiple first author uh, clinical investigators of many studies. International faculty at EuroPCR, TCT, TCT-AP, Singapore Live, India Live, and now Malaysia Live also. So I cordially welcome Dr. Sandeep Basavaraj to this scientific session. And moving on to our session anchor and the moderator of the session is Dr. S. Manoj from Kaveri Hospital, Chennai, senior consultant in cardiology. Sir is one of the India's leading intervention cardiologists with over 2 decades of experience in intervention cardiology, managing complex coronary and structural heart diseases. Sir has done more than 8,000 invasive cardiac diagnostic and therapeutic procedures. Sorry, sir, it is 18,000. Pardon me for the typo error. 18,000, more than 18,000 invasive cardiac diagnostic and therapeutic procedures performed as the primary operator. Recognized operator and educator, Sir is a fellow of the European Society of Cardiology, American College of Cardiology, and Society of Cardiovascular Angiography and Interventions. So I cordially welcome Dr. S. Manoj as our section anchor for this session. Now I hand over the session to our moderator, Dr. S. Manoj. Sir, over to you now.
Thank you, Nishant. It's a pleasure to join
along with my dear friend Dr. Sandeep Basarajaya, and also many of my colleagues from whom I've known for years. So I have the pleasure of also inviting the panel of chairpersons who are also esteemed interventional cardiologists from India, and they have equal number of experience as the speaker as well as the I have. So my pleasure is to introduce Dr. Amit Bhushan Sharma, who is the director and the unit head of cardiology from Paras Health from Gurugram, and he has a rich experience of over 20,000 radial transradial angioplasties and also in structural interventions. Also, my dear friend Dr. Nalin Mahesh Kumar, who is well-known figure in the interventional cardiology field in this part of the world, is head of the department and senior consultant at St. Gregorius Hospital, Paramala, which was initially founded by Professor K.M. Cherian, and then now he has been most respected interventional cardiologist in that part of the country. Has also extensive experience in complex coronary interventions and also ample publications as authors that has enhanced our understanding in the interventional cardiology practices. Also, my pleasure to introduce Dr. Jimmy George, a senior consultant cardiologist at Lizzie Hospital in Cochin, which is one of the hub centers of leading interventional cardiology volumes and speaks for their expertise and experiences. And he is also had a rich experience in coronary interventions and advanced cath lab procedures and a great clinical expertise and academic contributions with evidence-based cardiovascular care. I'm sure all these three people will enrich the today's discussions. And I would now invite Dr. Sandeep Basarajaya to give his insights into the recent understanding about the intravascular lithotripsy and some of the cadaveric experiments that has given significant understanding into how the calcified plaques would modify for the optimal PCI outcome. Dr. Sandeep.
Hello, everyone. Good evening. Thank you so much for this kind opportunity. Thanks, Manoj. In fact, Manoj and myself are in the same place in Malaysia, in a different room in the same hotel. We just had a great meeting in Malaysia. Can you all hear me?
Yep.
Yes,
And
indeed.
can you see my slides?
Yes, indeed.
Okay. So I will be giving some updates on the recent study we have conducted using shockwave IVL on human cadaver arteries. So it's more like a bench testing. And it's going to be published in JACC Intervention very soon because we have received some communication from them. Both the papers have been accepted. So let me begin the presentation. So we all know the difference between IVL and other non-IVL balloons. As you know, IVL balloon does not rely on the barotrauma because it uses sonic waves as compared to other balloons which uses pressure-based or a barotrauma-based approach. The nominal inflation for IVL is only 4 atmosphere as compared to other balloons, you need to go high pressure. Fractures you get from IVL are more deep as compared to the other balloons. And it does not affect non-calcified tissues, unlike other balloons which also affect non-calcified segments like a soft tissue injury is much more common. The effects from IVL are more predictable as compared to other balloons which can be unpredictable, especially in some heavily calcified eccentric lesions. So these are the benefits of IVL: no specialized wire you need, modify the deep calcium, no risk of embolization, you don't have to worry about protecting the side branch, and a low risk of barotrauma. The simplicity of its use makes it very unique technology. What do we know so far? We know that calcified coronary plaques pose a significant challenge in PCI. IVL is safe and effective in modifying calcified plaques using sonic waves inciting deep fractures to facilitate successful balloon expansion. So it modifies the calcium, so makes the vessel more compliant. We also know that IVL is effective in all kinds of calcium, whether the concentric or eccentric, with minimal tissue damage as compared to other calcium modification tools. However, we do not know certain aspects of IVL. For example, is there a dose-dependent effect in incremental of calcium fractures following IVL use? Do concentric and eccentric calcium behave in a different way for IVL pulses? So in our study, we wanted to evaluate this aspect. So we evaluated the dose-dependent effect of IVL shock pulses in calcified arteries. and to compare the differences in the IVL pulse dose between concentric and eccentric calcium. So this was a mechanistic human cadaver studies. If you go back to a paper published in 2025, as I said to you earlier, this was again a cadaver study. What it showed was that you get more fractures in the IVL as compared to cutting balloon or a ultra high pressure balloon, which is OPN. But you see here, the tissue damage is yellow is the medial injury is very less in IVL because it doesn't affect non-calcified tissue as compared to the other balloons, which gives a lot of damage to the non-calcified areas. So this was an investigator-driven study supported by a grant from Shockwave Medical. The rationale was to understand the dose-dependent relationship between IVL pulses and calcium fracture formation. Now, why is this important? Because it aids in effective use of IVL pulses to achieve maximum lumen gain, and also to understand how the concentric eccentric calcium behave. You can then tailor your treatment based on what the results show. So the study design was, cadaver hearts who had a high risk of calcium. So for example, patient who had a CKD or diabetes, dying from a sudden cardiac death, those hearts were screened for calcium using an X or a CT. And this is how the calcium looked on a cadaver heart. And then suitable hearts were subjected for an angiogram. This is angiogram done on a cadaver hearts. And we also did the IVUS and the OCT and the micro CT. Calcified lesions were identified as lesion more than 50% stenosis on angiogram, identified on also intravascular imaging, and we identified lesions which had a minimum length of 15 millimeter. The balloon sizing was based on intravascular imaging analysis, and we ensured no pre-treatment of the load. So essentially, if lesions were not crossable with IVL, we excluded them because we didn't want to treat them with a POBA to avoid any confounding results. So this was the protocol. This is a very busy slide. I would like to take some time to explain this. So essentially, on the day of the procedure, we did the intravascular imaging on these cadaver hearts, and then we treated the lesion with 10 pulse of IVL. Then we repeated the intravascular imaging, and then we also did the micro CT. Then the next pulse, which was another 10 pulse of IVL, micro CT, and in cycle 3, 4, and 5, we gave 20 pulse each. And at every stage, we ensured the micro CT was conducted. And finally, we delivered the 120 pulse in the 6th cycle. And then we did the micro CT. And finally, we subjected the sample for histological analysis. But we have to understand that we have ensured to do micro CT at every stage of calcium fracture or IVL pulses. The concentric calcium was defined as angle of 180 degree or more. You could see here. So this is a concentric calcium on micro CT and also on the histology, whereas eccentric calcium was less than 180 degrees. What are the endpoints? We're looking for calcium fractures evaluated for dose-dependent effect by micro CT and histology with co-registration, and to compare how the concentric and eccentric calcium behaved. So we identified 5 cadaver hearts which had 15 lesions that met the criteria, and they were treated with IVL. And from each of these lesions, we identified 2 micro CT and histology cross-sections. So essentially 15 lesions, 2 samples from each lesion. So making 30 cross-section analysis. So, hello? Okay, so the 15 lesions met the criteria. And as I said, from each lesions, we identified 2 sections of micro CT and histology to give you the total 30 sections. So this is how we selected. So we ensured the lesions were selected where the emitters were placed. And then we analyzed these sections for micro CT and the histology. So this is the overall result. We had 30 sections, as I alluded earlier. And the calcification arc was around 150 degree with a calcium thickness of 1.3 millimeter. We had 27% of lesions which were concentric calcium, and we had 73% had an eccentric calcium. This is the overall result. So look at this. we had fractures, 25% of fractures seen in the first 10 cycles. And then by 20 cycles, almost 50% fractures were seen. So almost half of the fractures was seen in the first 20 cycles. But then there was a slow but a consistent increment in the calcium fractures. And this is a micro CT demonstrating that. So for example, here, this is a pre, and this is a 10 pulse, 20 pulse. And as you could see, as you go across, you see more and more of the yellow arrows, which basically means you got more and more fractures. And you can see in the cross section and also in the longitudinal sections. So more pulse you deliver, you get more fractures. How about concentric and eccentric? How did they behave? So this is a concentric calcium. So as I said, we had 8 samples which had concentric calcium. And as you could see here, in concentric calcium, you had increment in the fractures, but more importantly, most of the fractures happened within the first 20 pulse. Almost 75% of the fracture happened within the first 20 pulse, but then there was an increment, but small. So at 120 pulse, you had almost 90% of fractures in concentric calcium. So the bottom line is you achieve fractures very early on in the concentric, but a little increment all the way through. However, in eccentric calcium, on the other hand, you saw very less fractures to start with. You could see here only less than 40% of fracture at 20 pulse, but we had more consistent increment as we went across. But you have to understand here that in 50% of cases, we didn't see any fractures despite using the whole 120 pulse. And this is a graph showing how the concentric and eccentric calcium behaves. So you see here in concentric calcification, you see more earlier fractures, but with a little increment. Whereas in eccentric calcification, it showed low fractures, but more consistent across the pulse dose. And this is a table showing the mean number of IVL pulses required to achieve fractures, the first fracture. So for example, in concentric calcium, the mean pulse you needed to see the first fracture was around 28.7, whereas in eccentric, it was 75. And we also identified what was the independent predictor for a calcium fracture occurrence. It was not the thickness, but the arc. So if you had a bigger arc, which means almost getting to 360, it was an independent predictor of seeing an earlier fracture as compared to thickness. And each 10-degree increment in calcium arc, we saw almost 8.1% increase in the hazard of first fracture. And this is just an example showing, you see here, this is pre, you can see the clearly dog boning of the balloon. And within 10 pulse, you see the balloons nicely expanded and you see multiple fractures in concentric calcium. So in concentric calcium, you just need 10 to 20 pulse to achieve fracture. We have to understand there were some limitations in the study. One of the main limitations was we had a very small number of cadaver specimen, and we also had only 2 frames per lesion. Maybe you could have taken more frames, but for this study, we only took 2 frames per lesion. You also understand that physiological conditions such as cardiac motion and pulsatile flow were not reproduced, although we ensured the intraluminal pressure was constantly maintained by inducing a saline flush throughout the procedure. IVL was not followed by a subsequent high pressure post-dilatation, which normally we do in standard practice. So for example, if I'm using an IVL, after the 120 pulse, I take a high pressure NC balloon to give more fractures. That was not done in our study. Nevertheless, the conclusion in our study, the fracture incidence following IVL increased with higher pulse dose delivery, but varied according to calcium morphology. Concentric calcium fractured early, needing only 10 to 20 pulse, whereas in eccentric calcium, you need a higher pulse. The mean pulse you need for 70 pulses to see the first fracture. How does this impact clinically? So for a focal calcification, irrespective of calcium arc, operators can use the entire 120 pulse to get the maximum benefit from the incremental increase in calcium fractures. However, in long segment of calcified lesions with mixed morphology, operators can use a co-registration from intravascular imaging to mark the concentric and eccentric calcification to tailor the treatment. So I'll show an example. So this is a concentric calcium or like a focal calcification in an LAD, and you could see the dog boning of the balloon. We did an intravascular imaging, and you saw a concentric calcium here. And you see here, we gave 3.5 by 20 millimeter NC balloon. It failed to open. And then we used IVL, and you could see here, cycle 1, 10 pulse, cycle 2, 20 pulse, and by cycle 3, the balloons fully expanded. So by third cycle, we had achieved a good balloon expansion, and you see the calcium fractures on IVL, lots and lots of fractures. Now, would you stop at 30 pulse? So if this was a patient with only one lesion, I would continue delivering the pulse, because our data suggests even in concentric calcium, you will have some increment in calcium fractures. So keep using it so that you can use all of it. Whereas eccentric calcium is different. So for example, here, you see here, there is a calcification in the middle AD. We did intravascular imaging, and you could see the eccentric calcium with not much calcium on the other side. We did a rotational atherectomy here because there was a wire bias. After this, we had a 5.6 millimeter square lumen gain. Then we used a 3.5 IVL. We used the whole 120 pulse, and then did an NC balloon dilatation. And you see here, we achieved a bigger lumen gain here. So you could see the lumen is now almost 8.2 millimeter square. Then we used a stent, and we had a good result. And the IVS shows we had almost close to 10 millimeter square MSA. Whereas if you've got a long segment of calcified lesion, mixed morphology, for example, here you have a nodule, you have an eccentric calcium and a concentric calcium in the RCA. In this case, you can tailor your treatments. For example, here I would give maybe 20 pulse, but I would spend most of my pulses here and here. We also had a second aspect of the study. So as you know from this flow chart, we measured micro CT at each aspect, but we also measured intravascular imaging after 10 pulse and 60 pulse and at 120 pulse. So we use this data to generate another study from this analysis. We all know intravascular imaging improves clinical outcome. One of the critical benefits we obtain from intravascular imaging is the ability to aid and confirm adequate lesion preparation by identification of calcium fractures. But what we don't know is that how IVUS is more sensitive than OCT, because IVUS is the most commonly used tool globally, but how is it sensitive compared to OCT and a micro CT? So in this study, what we identified was we had of the 30 fractures we saw on the micro CT. So we had 30 fractures on the micro CT, but on the OCT, we were able to see fractures in 60% of cases, but not in 36.7% of cases. So there are fractures on the micro CT, but we did not see any of them on the OCT in 40% of cases. Whereas in IVUS, almost 60% of fractures were missed. And if I show you some examples here, you see here on the micro CT, you can clearly see the fractures. But on the OCT, you cannot see anything, not on the IVUS. Whereas here, the fracture is more obvious on the micro CT, but you see a very, very subtle fracture on the OCT, but nothing on the IVUS. Whereas as the fracture becomes more and more wide, for example, if you see here, the fractures are much more obvious on the micro CT, then you see them on the OCT and also on the IVUS. And we also identified an area under the curve to identify what is the minimum width of fracture you need to see on a OCT before you can see it on the IVUS. It was 105 micrometer. So if I show you this here you have a fracture of less than 115 micrometer, and you see the fracture on the micro CT, maybe subtle on the OCT, but nothing on the IVUS. Whereas if the fracture width is more than 115 micrometer, you see it on all three modalities. So IVUS, OCT, and micro CT. So the conclusion is OCT is better than IVUS in identifying calcium fractures, but even with OCT, you can miss 40% of fractures that can be seen on micro CT. So IVL produces fractures that may be not visible always on intravascular imaging due to resolution issues, due to lack of penetration of sound and light waves. Hence, absence of fracture does not indicate inadequate lesion preparation. How does this impact clinically? We should not be obsessed with seeing fractures, because you may have fractures which are beyond the resolution of IVUS and OCT. we should be looking for surrogate markers of calcium fractures. So for example, if I show you this case, this is a RCA, heavily calcified, and we did the intravascular imaging acoustic calcium nodule, and this is a sync vision showing that there's a clear calcium nodule. Here we used a IVL 4 millimeter, and we spent the entire 120 pulse here. And this is a POBA post IVL. You could see the balloon is much, much bigger here now. So if you compare the POBA before the IVL and POBA after the IVL, you can see clearly there's a difference in the balloon size. But also, if you look very carefully, when I zoom this in, the wire bias has completely changed. Here, the wire bias is extremely on one side due to presence of calcification, whereas here, the wire bias is completely changed because more central. So with IVL, we have caused a fracture, which may not be seen on the IVS or OCT, but clearly you can see the difference in the way the balloons have been behaving. You could clearly also see on the lumen gain, pre-IVL and post-IVL. Finally, I would like to put some slides on how to use IVL, because we all use IVL, but we have to ensure there is no air, because the moment you have air in the balloon, it reduces your output. For example, here there is no air and you got a maximum output. Moment you have air, your output comes down. So what we tend to do in our center is, you could see here, we are using a 3-way tap, and we are aspirating with a 20 ml Volox syringe, and we aspirate few times to ensure the whole air is removed, and then we connect to the indiflator. So with this way, you're minimizing, you're taking all the air out of the system, and then we can deliver maximum pulse. And finally, with the IVL, for example, here, we have placed an IVL here, but you cannot see the markers, the emitters. All you see is these balloon markers. Whereas if you use a sync vision or a stent boost or any other system you have, you can see clearly very well. So for example, here, we can see the stent, the IVL emitters very clearly. And this is the calcium. So we can place the IVL emitters right on the calcium to enhance the delivery of the shockwave. And these are some of the other views where you could see the position of the IVL right on the calcium, so you get the best benefit. Thank you so much.
Thank you, Sandeep, for those wonderful insights into how to understand the wonderful technology of intravascular lithotripsy through its sonic waves creates a significant amount of plaque modification in a very densely calcified condition. And this has been troubling interventional cardiologists to optimally address this clinical challenge significantly. So I would invite comments from esteemed chairpersons, and then we would proceed on.
Sandeep, great study, a lot of intricate work that you have done. But I strongly feel that you missed one step, which is the most critical step. Post-dilatation with an NC balloon, that would have proved as the proof of the pudding. So that could have given us a much better view of whether you have done a job, rather than looking at the micro CT, the OCT, except the biopsy. Rest everything would have been supplemented adequately with a post NC balloon dilatation. But then your post histology would be damaged very badly if you do a post NC balloon dilatation.
Yeah. I mean, I think, Dr. Mahesh, you made a very good point, because this is one thing after the study was conducted, I felt we should have done an NC balloon, because that's a normal practice, as you said. I don't know if that would have influenced the study in terms of seeing more fractures. Maybe it would have been. But one thing, you're right, we didn't do that aspect. That's one thing, maybe it would have changed. Maybe we would have seen more fractures.
Sandeep, was the vessels volume conditioned, or because it's a gravel out? And you said there was no pulsatile flow. So was it adequate enough to maintain the normal U volumic state in the arteries?
Yeah, let me show you. Actually, this is interesting. If you have, let me just reshare the screen, because I want you to see this part, which I didn't, because in the interest of time, I didn't want to kind of show, but let me show you this one. Can you see my slide again?
Yes, it's visible.
So this I did not show it because in terms of time I didn't want to. So essentially, if I show you how this was done, because it's interesting to know. So essentially, this is how we did the study. So this is the angiogram done on the heart before dissection. So this is the way we did the angiogram using the just the sheets. Okay, once we confirmed the calcium, then they had a dissection of the arteries. This is how we did the PCI. So this is your Terumo sheath. So we didn't use any Judkins catheter or anything. And then you could see here, we are wiring the lesion using a fluoroscopy there. And I don't know if you see here, can you see the saline here? So this is connected to a saline bag. So we are constantly perfusing the artery with saline. So even here, this is connected to a saline drip, and this is constantly perfusing the artery, which is why it's all very, very wet here, because there's a constant saline flushing through the artery, kind of trying to mimic the blood flow. And this is how a fracture was done. So you could see here, we have covered this with a jelly thing. That's the arteries inside, and we're delivering the pulse. And
Was
this
the
is the way
exit,
the
okay, was the vessel
Yeah,
exit constrained to retain the flow volume there? Because otherwise, whatever flush would exit through the vessel, so it would remain perhaps partially collapsed.
Yeah, I know. Look, you can't mimic exactly how the human arteries work, but this close we can get to in these kind of samples. So I'll tell you the other problem we had was this. Okay, so remember we did 10 pulse, and we have to take the sample for a micro CT. Okay, now imagine you got a wire through it, so we can't leave the wire for a micro CT because it causes artifact. So we have to change that wire to a wire which does not have the metal. So we use a fish string. You know, the catching fish, we use that string. So we used a fish string. We put a microcatheter, like a fine cross through it. Then we put a fish string and took the sample. You see, this is a fish string here. There's a fish string, and this is just a gel foam, like a shaving foam. And we put this in a thermocol and put it in a micro CT here. This is a micro CT, and to see the fractures. So this was quite an intense study, Manoj, because each of these, in fact, I was there for a week, and we only did 5 hearts. So each day we could only do 2 samples because you have to deliver, because micro CT takes time, because it takes at least 1 hour to get the whole result. So then we have to stop, and then you have to start again. So it was quite an intense study to get it. So this was the whole team I did with. So yeah, so I thought I'll share this one.
Comments from other chairpersons?
So that now I am more respectful for the study. That's hell of a lot of work you put in, man.
No, thank you. It was a hard work, but it's worth, because to get into JAK intervention, we have to do this work.
Yep.
I think excellent presentation, sir, and excellent research going on. So I think with more IVL becoming more rampant, now the emphasis will be more not on debulking therapy, but actually plaque modification. And as you clearly showed, we should not be obsessed with getting fractures, because the OCT will be missing majority of the fractures, which is less than 15, which I just realized the value right now. And it is more about lesion preparation and getting a full proper sizing done rather than getting obsessed with fractures. So a lot of learning, taking take home points.
See, the one thing I would also say is that this is my practice recently. If I have an eccentric calcium with a good wire bias, okay, before I use IVL, I take a rota. So I take a rotablation, it's like a 2 burr, you drill, and then use an IVL. So IVL with rotablation it gives you the best expansion of the lesion.
And will your strategy modify in an ISR patient? Would you still go ahead with rota first, or what? How would
No,
ISR?
ISR depends on where is the problem. If the problem is behind the stent, let's say you have a big calcification behind the stent, rota will not work. In that case, you use the IVL, and then you take a high pressure balloon like an OPN or a AccuForce with a high pressure to expand the stent. If the stent is fully expanded, and if the problem is within the stent, like a lot of intimal hyperplasia calcification, then you can still rotablate within the stent if there's a lot of calcium. But if it is a non-calcified tissue, you use a cutting balloon. But if it's a calcified tissue, you could rotablation and IVL.
Another important point that Sandeep brought out was, of course, a simple aspect of not having an air bubble inside the balloon, because air is certainly a compressible thing. So most of the sonic waves will compress the air rather than delivering it outside the balloon device, and
Yes.
therefore but of course this applies to almost any balloon or any stents also, because if you have the balloon, the stent delivery system, or the balloon having bubble, as you inflate to higher pressures, you could distinctly see that on the fluoroscopy the air getting compressed, and that would not actually deliver the required expansion kinetics on the stent itself. So I think in any form of balloon delivered systems, one should not have any air bubble columns inside, and that applies universally also, but particularly so with the shock wave, where it would impede and the impact of the sonic waves, which we want to have it delivered to the vessel wall. And other aspect is the medial. If suppose the media is also calcified, I suppose that would also get affected, I believe.
Yeah. It's a good thing about the IVL is it gives you deeper fractures all the way to the median adventitia. Now, what you mentioned about the occurrence of air, you do all the thing to ensure the air is not there when you start. But as you go on, the third or fourth cycle, air will eventually develop within the balloon. That's the way the mechanism shock wave. So if you have a three-way tap attached to your deflator, you could then suck again and then take the air out and then start the pulse again. So I think it's important to do these things, especially when we pay so much for these balloons.
So what is the reason sometimes we don't get a pacemaker spike and sometimes we get a spike? So sometimes we get a spike and sometimes we don't. So what is the reason? Is it the air which is to do with it?
No, it's not the air. It's just the way, I don't know, some
Conductivity.
patients behave, probably connected to the patient. So it's nothing to do with the air.
Can we move?
I think Jimmy has joined now. Jimmy, he probably wouldn't have missed the session addressed by Sandeep. So Sandeep, last questions on your presentation. So now that we understand that the microfractures are, which are invisible on the current generation of intravascular ultrasound, intravascular imaging systems. So regardless of whether we see the fractures or not, the calcium algorithm definitely shows that indicates that we should do a imaging after the calcium is modified to see whether it's optimally modified or not. So we certainly know now that whether you see or not seeing the calcium
You should do it.
fractures, their microfractures are always there. So should we have that in the algorithm?
No, I think you should still do it because you can still see fractures. You can see the lumen gain. So I think it's worth. If you already opened a intravascular imaging for pre-procedure, you might as well do it. But as you said, if you don't see a fracture, doesn't mean there's no fracture. So look for the balloon expansion. Look at the wire within the balloon. The wire bias will change. I think those things are surrogate markers.
Great. Yeah. I think Mahesh, could you invite the speakers? Because I think we have 4 speakers and sessions. We'll move ahead. Sandeep, I hope you also stay and contribute to the discussions.
Yeah, I will stay. I'll stay.
Yeah. So let me invite Dr. Akhil Sharma for his presentation on Shock the Rock with Precision Image-Guided Calcium Modification. And then I'll come back to you, Mahesh.
No sweat, I'm here to stay.
Thank you.
Good evening, all. Am I audible and my slide visible to all of you?
Yes,
sir.
Dr. Akhil. Yeah.
Good evening, all. So today I will discuss the Shock the Rock with Precision Imaging Guided Calcium Modification, as Dr. Sandeep already highlighted the mechanism, the effects, and how we can approach our calcified lesions with the help of the IVL. I will try to discuss my topic with the help of 2 or 3 cases and how we can have the best imaging and I can say best suitable calcium modification modality to use in patient. So these are the example of three cases I will discuss, and as we all are very fond to have the angiographic images and try to analyze it again and again, but it's very difficult to. I can say that today's era it's very difficult to understand what pathology inside the vessels and how we can treat it optimally. We can treat it with the help of different modalities, but if we want to have the optimized result and optimal outcome from the different devices, we have to understand first the pathology, then we have to opt any kind of the modality. So only angiographically we can identify the calcium, lesions, vessels anatomy. But when we come to the opting the different modification devices, it's a very, I can say that very difficult to understand. So these are the three cases. You all can see that there the severe calcification, which is visible, long calcification in case 1, case 2, and case 3 is the LCX of case 3, and all three vessels, I can say that angiographically we can evaluate, but after imaging, they all require different kind of the modalities. I will discuss one by one. So how we can identify the calcium? We all aware by the CT scan, angiographically, which we are more obsessed, I can say that, or by the OCT or IVUS. Which modality should we use is depend on the experience of operator, different situation, and what we exactly want to understand in the intravascular pathology. It can be governed sometimes by patient-related factors like the poor LVF, raised LVDP, or the renal dysfunction can guide our choices. Calcium modification tool, as already discussed, we can use the different kind of the balloons. We can have cutting scoring balloon or super pressure balloon like OPN, laser, lithotripsy balloons, rotablation, and the orbital and combination of the different device in different patient. But it's important, we all aware that the MACE event is increasing as the calcification increase, and over the time as the lithotripsy balloons or some advanced device in practice, the rotablation is huge decrease over the last 2 decades, I can say that. So let's discuss by the case. This is the case one, which was a 58-year-old female presented with the stable angina class 3 with unstable angina 15 days back, where patient has the T inversion V1 to V6. Yeah, LVEF normal, syntax 34%, TBD patient, advice EAVG, but patient refused. So we opt this patient to do the PCI to LED. As I discussed, this was the first case which I shown in my first slide. So in angiogram, you all can see the LED is the diffusely disease, proximal to mid part has the severe calcification, which can be visualized on the still frames. Long disease and a large diagonal, which also involved in the distal margin. So we can say that this is the severe calcification and require at least any one type of the or the combination of the calcium modification devices. So before what we are going to achieve by the imaging, we have to understand why we are doing imaging and how we should interpret it and how we should react with the imaging of this patient. So we opt in this case is OCT. As I earlier mentioned, it's always the operator's choice or availability of the device which you want. So in this case, initially we have struggled to cross the catheter. So we did the predilation with the 2 mm of the balloon, and after predilation across the OCT catheter and do the imaging. So you all can see that the thrombotic or some fractures which done by the balloon, and you all can see the eccentric calcium, thick calcium, which have almost 7 to 8 mm of the thickness, and the long involvement about more than 20 mm of the length of 2 centimeter of the length of the LED. So after this, when we have done the imaging, we have to analyze the images, what we identified. So as we all can say that we identified the eccentric, thick calcium, which involve almost 270 degrees of the vessels, involve more than 15 millimeter of the vessel length. So we have to calculate the different scores for the OCT as well as the IVUS. I'm not going into detail, but in this case, it's the clear cut, is the rule of five, which clear cutly showing that the risk score is more than 2. So we decided to go for the any kind of the calcium modification modality used in this patient. And this is the I can say the algorithm how we can use the different kind of the calcium modification devices, which already discussed by the previous speaker. But in any case, if we have the deep calcification, I can say that the scoring balloon or any kind of the balloon is the much better way. If we could not achieve this optimal result, then we can go with the IVL, orbital or rotational atherectomy. For these superficial lesions, as I earlier mentioned, we have to assess the image, calculate the score, and then we have to decide which modality we require for our patient. In the patient who has the higher score, we can opt for the IVL or orbital or as well the rotational. Most of the cases who have the deep calcium, eccentric calcium, where we can go with the IVL to achieve desirable results. For the nodular calcium, we all aware these are the very difficult lesion to treat by any kind of the modality, but combination of the orbital atherectomy or rotational atherectomy with the help of IVL can have the better result in these kind of the patient. So for this patient, as the score is more than 2, patient had the eccentric calcification, long lesion, we decided to go with the IVL 2.5 into 12 mm, did the multiple therapies to start from the distal to proximal area, adjusted all the pulses in this patient, and after that we did the OCT, in which we demonstrate nicely the calcium fractures. As earlier speaker rightly pointed out, we should not always look for the fractures, but if we can identify the fracture, they give satisfaction at least in the efficacy of the therapy. After we did the post dilation, implanted the 2 days, and again did the post dilation with the NC balloon at the high pressure with the 2.5 followed by the 3 into 10, and achieve this final result, which I can say that the very satisfactory result for this patient. This one is the second case, a patient of the anterior wall MI presented with the recurrent ventricular tachycardia, for which he implanted the ICD in outside and refer for the management of the proximal LED lesion, which is severely calcified. You all can see that the had the proximal to mid lesion, had class 3 of the calcification. So again, for the deciding the therapy, we did the IVUS imaging for this patient, and you all can see that there is the 360-degree calcium concentric calcium in the vessel, which had the long lesion, almost 20 millimeter in the length. And so we decided again to go for with the intravascular lithotripsy. Definitely we can use the cutting balloon in this patient, we can use the rotablation, but as I earlier mentioned, the high score or severe calcification, crossable lesion, so we opt for the 3 into 12 mm of the lithotripsy balloon. And you all can nicely see that there is initially the dog warning in the balloon, but over the time when we did the multiple pulsation for this patient, we have the nice expansion of IVL balloon. Again, we did the IVUS. You all can see nicely the fractures in the multiple part of the concentric calcium. After this, we did the 3.5 mm of SGNC balloon, acute force to high pressure by dilation of the vessel. Then we implanted the 4 into 40 mm of the DES. After that, we did the post dilation with 4.5 of the balloon and achieved this result, which is satisfactory, nice result achieved, and area is about 12.7 millimeter square, which is quite reasonable for this patient. And this is the final result angiographically. So I can say that the precise quantitative lesion assessment by the OCT or IVUS, any kind of the intracoronary imaging is important, but it's not the imaging. We have to understand the pathophysiology. We have to respond according to what we found in the imaging. It's not never better to opt your device of modification before the findings of OCT or IVUS. So always identify the pathophysiology, identify the quantity as well as the distribution of calcium, then choose your best probable modality to modify the calcium. Most of the time, or I can say the more than 50% of time, to you require the combination of the modalities, which may be combined with the cutting balloon or rota, or it may be the IVL rota or orbital or laser in the your patient for have the better or best expansion. Coronary calcification always a hindrance for the better result for cardiologists. IVL balloon, as I earlier mentioned, that this is the device which can be used without harming much your vessels and without having the increased complication rate in your patient. Sometime balloon rupture may be reported, but it's very less less, or I can say the non-significantly reported in the practice. Preferential effect of deep calcium compared to the other ablation techniques is always a advantage. And I can say that the lastly and final word that this is the simplest ablation modality or modification device which can help a patient in the severe calcification. So thank you all for your kind attention, and I am here for any comment or question, please.
Thank you, Professor Akhil Sharma. Let me ask the chairpersons to take forward the discussion along with the expert panelist from Indore, Dr. Shreyas Tatad and Dr. Gaurav Singh, and engage in the discussion further based on the cases presented.
Manoj, you handle, man.
No, go ahead.
That's fine. I've got nothing to add. It's like a professorial talk, covered everything under the sun, and gave us the theory class as to why we should do what we should do. Great cases too.
Thank you, sir.
Yeah, as he rightly said, this one of the tools of effective calcium modification that requires a very less learning curve, unlike the atherectomy devices, which requires a number of mentoring and also understanding the nuances and various other techniques and tips and tricks to have a safe atherectomy-related calcium modification. The shockwave lithotripsy has definitely penetrated the hands of even the youngest interventional cardiologists for calcium modification to be the best effective manner that we currently know of.
I agree. I think it's a very nice case. Congratulations for this amazing case, Dr. Sharma. I think you showed that. I think most important is to keep. I know. I told you in my study that you cannot see fractures in all the cases, but you still have to do it. I think that's the key. I think that's what you shown nicely. And as I showed in my study, that concentric calcium is the most easy to crack. So sometimes if you have got a long lesion with 2 or 3 areas of eccentric calcification, maybe for concentric, you could just try an NC balloon, and then you can reserve your shock wave for those areas where you need more shocks.
Very nice presentation, Dr. Sharma. In fact, some of the lesions, especially your case 2, sometimes if we had not done the OCT, we would have thought that probably we could try a scoring balloon or a cutting balloon. But then you very nicely demonstrated the length of the calcium, the depth of the calcium, the arc of the calcium on OCT, which made us change our decision. Otherwise, angiographically speaking, sometimes we may be using a cutting balloon or a scoring balloon first, but very nice demonstration.
Sandeep, on the calcium modification after you apply the IVL, and perhaps now you have the current generation C2 plus where 120 pulses are delivered. And is it a necessary protocol to understand that the calcium needs further modification by the use of NC balloon being looked at in 2 orthogonal projections to see whether it's evenly expanded? And then you take further shockwave delivery, especially the understanding from your cadaveric experiments that less than 270 degrees eccentric calcification would require much more focused delivery of pulses?
Yeah, I always do it actually. Even when the shockwave expanded, I still take an NC balloon and I go up to 16 atmosphere 1-to-1, and then I deliver the stent or whatever DCB if you want to. But the thing is that for eccentric calcium, it's a massive challenge because as you saw in the shockwave, even 50% of them is fracture, but obviously it was in the cadaver studies. So I tend to now use combination therapy. some form of atherectomy, orbital or rota, if I have a good wire bias. But you have to take a bigger burr, like a 2 burr, to make sure that you really crack the intimal. So this is the next aspect of the study we're trying to look at. After atherectomy, I think you get a better transmission of shockwave into the adventitia or the media. So I think if you got some really severe eccentric calcium, I think rotational atherectomy with IBL is very, very good.
Has there been any experiments of rotational atherectomy with the micro CT also? Perhaps because there is a impacted the back. Not only that it shaves off the crown of the calcium, eccentric calcium, but also has some amount of mechanical impact on the calcium to show any microfractures.
No, there's no study. We are trying to design one, Manoj. That is the next my mission to do it. But it needs a funding, so I'm trying to get some funding for it. So that's the next aspect of the study.
So in the cases
Yeah,
of micro CT, do you have a particular cutoff for the Hounsfield units? How much calcium is there on the micro CT to determine what type of strategy I'm going to follow? If it's more than 60,
No. My micro CT is only for studies we did. But if you are doing a if you're doing a CT, if you're doing a CT before angioplasty, which sometimes some centers do it,
Yes.
if you have a really good CT service, like especially with the new photon counting, you can
yes.
measure the thickness of the calcium.
Mhm.
And if you've got really thick eccentric calcium, then you should decide what you want to do. So as I said earlier, if I see some really good thick calcium eccentric, and if I got a good wire bias, I tend to rotablate and then use a shockwave. Sometimes you have to use both of it. But if it's a concentric calcium, you just use shockwave, should be fine.
Yeah, thank you so much for the engaging discussions. Let me invite my dear friend Dr. Mahesh to tell us about his case on calcified left main disease.
So it's like sing for your supper. I have to do a small talk before I can go to my case. This I was requested by the Translumina team to present this. This is the Bali study which was presented at Europecia. We know this part. So inclusion criteria for the study was severe angiographic calcification as defined by Dr. Mains and all in 1995. And exclusion criteria is a standard STEMI, CTO, less than 35 in EGFR. So it was divided into 200 cases, lithotripsy and conventional picture. And rotablation was, if criteria warranted, then either in the lithotripsy arm or in the conventional preparation arm, rota was used. 1 year follow-up, the imaging modality was OCT. So I strongly believe that OCT is the imaging modality for calcium. So that if you can do, you can be more convinced than procedure failure, composite no or failed stent delivery. OCT assessed residual area stenosis more than 20%. TLF at 1 year, myocardial infarction, revascularization or cardiac death. Assumed 15-point difference. That is why the number of 200 came in. Everything was balanced. Procedural characteristics were balanced. The lesion preparation was almost 100% of the cases, lithotripsy balloon was used in the lithotripsy arm. Surprisingly, in 2% of conventional arm also that we used. Non-compliant balloon, 69% only. Cutting or scoring balloon, 12%. And super high pressure balloon in 1%. Largest balloon diameter, 3.5. Balloon pressure, 15 atmospheres. Stent implantation, post-dilatation, everything was standardized. So 99 were assigned to lithotripsy, 101 assigned to conventional. 99, they were very good for post-procedure follow-up. The primary endpoint, failed a no stent delivery, 1 per patient in lithotripsy, conventional, none. Residual area, more than 20, 32% in lithotripsy and 44% in conventional. So the moral of this line is that if you go and try for perfection from the word good, that is when you land up in trouble. So probably it was a good idea to leave this 32% alone. If you had gone ahead with an OP and NC balloon, you may have burst a artery and created more problems than help. But that is supported by the TLF at 1 year is 4% here and 10.9% here, proportionate to the residual area stenosis. Cardiac death, myocardial infarction, clinically driven revascularization, not very significant. Myocardial infarction flow limited dissection was 6% in lithotripsy. Perforation was 4%. Although the perforation was described as perforation, 5 perforations occurred. 2 were distal by perforation, both in the lithotripsy group. That's a sad thing to. So there are only actually 3 perforations, 3%, and that is because of the balloon. So instant MLA, mean standard difference, lithotripsy had 0.5 millimeter more, and residual area stenosis minus 3.3% in the lithotripsy arm. So obviously there is a better this thing. So the summary was concluded was that in patients undergoing PCI, lithotripsy is a very good thing that we all knew, but this study just concluded the thing. Now I will just come to the second presentation. Just that's my case that I'm supposed to present. So this case is a slightly old case. I'm sure Manoj may have seen it. So this is places where your imaging and your IVL balloon can be of immense help. So this is a 65 male with diabetes, hypertension. Incidentally, there are 5 IVL balloons in Indian market. I've used all the 5. What I feel about them is a different talk altogether, but Shockwave is definitely among the best. 65 male, diabetes, hypertension, stuttering, angina with worsening 2 days, good LV, creatinine is borderline. And these are the lesions that we saw. So there is something sitting at the junction point there. Multiple views just to show you. So initially, my opinion was because of stuttering angina, I thought it would be just a thrombus. So I left him for 24 hours on tirofiban infusion. Nothing happened. So the next day we decided, okay, let's go ahead and do what we can. He has a history of this is a OCT that we do. We do saline OCT. So you can see that the thing gets pulled back, but there is no contrast that's being used. This is the first slide which I missed was the LAD saline OCT. The next what we did was when the OCT was done also, we can see that the lump of whatever it is still there. And this is the OCT picture. So it is an old case of angioplasty. This we came as a surprise to us also, because suddenly he told me on the table that once this is the second time I'm going through the same procedure, a pharma by occupation. You can see that the lesion from the proximal calcium significant. This is the LAD. These are the slides which shows you 360 degrees, more than 4 millimeters, some places 1 millimeter, 1.5 millimeters, practically everywhere. So you can see that this is the dissection post the gentle dilatation I had to do to get my OCT catheter in. And this is a circumflex peron, equally dangerous. Luckily, distal circumflex was free of calcium. As we came to the mid circumflex onwards, as you can see, there is calcium beginning to appear. And at the ostium, it is just heavily calcified. I'll show you there is 7.8 millimeter length of calcium proximally. This is the distal part. This is the mid part. There is a calcium there also. This is the proximal part. This is the ostium. This is the ostium. Practically, it is actually 360 degrees of calcium, and there is heavily thick calcium. And then we go on to the left main. So the strategy was, now we decided that, okay, we are dealing with calcium. So now you see the positioning of the vessel. The more amount of calcium has gone into the circumflex, according to me, than the LAD. So the fresh OCT balloon, fresh balloon, IVL balloon was used into the circumflex. Now, there are 2 things that you should remember in doing the left main bifurcation IVL. Couple of things. One is that you give adequate gap between 2 pulses so that the guy gets time to breathe. During your first balloon inflation, there might just be a significant drop in BP. Second inflation, you'll find the guy is tolerating better. Third, fourth, fifth, he'll be happily taking it. There'll be no issues. So you don't overdo it, but then you should remember that it is the first inflammation that's going to create problems for you. Now, suppose in the first inflation, after you delivered 4 pulses, there is a crash in BP. Don't hesitate, deflate the balloon after 4 pulses. After the 4 pulses deflation, you wait for the guy to come back to normal, increase, and then deliver the rest 6 pulses in that cycle. So even in between cycle, you can pause and deflate and then go ahead and do it again. So this is the moment I did that, you can see that shadow has disappeared totally. It was a circumflex ostium that is the root cause of all the trouble. So then after that, we went into the LED. This time the balloon, I kept a little bit into the LED and a little bit into the left main because I wanted a good debarking of the left main also. And then later on, it's all just science. We did a post. I always do an NC dilatation. Now, post IVL, if I don't get an NC dilatation that is adequately good enough, then I image. Otherwise, routinely I don't image post IVL. I presume that I have done my job. So if I don't get an adequate expansion, I image and then decide between an OP and NC balloon and go to high pressures or a cutting balloon. These are the two options I have, either a Perta or a Wolverine. And one of those balloons I use. This is the way I tackle. I don't believe in going back with another 2.5 lakh rupees worth of IVL because it's just not practically possible. Too expensive, to be precise. So luckily we had a very good result with this much only. And this is the OCT. OCT does show fracture most of the times. Okay, if you have done a good job and you have done this OCT was done because I wanted to present this case. Don't get carried away. Don't have this thing. So this is a post IVL cut. You can see good cuts there all over the place. You can see cuts. There are fractures. The ostium has been shattered, and we have got a very good result. So that is how it worked out. Then we went into the standard protocol of stenting the circumflex, then stenting the left main. Once that was done, we got fairly good result. Then we did a pot. Then we recrossed and did a kiss. Once a kiss was done, the pot was repeated, and this is the final result. So how do we look at the final result? The LED post, you can see that the distal stent has also been, we post dilated and we did a little bit of a lithotripsy there also. Then little bit of, there is prolapse in the tissue, this thing, which is left alone because it was not affecting the flow. Distal expansion was 100%, proximal was 95%. These are the images to tell you that it's come out really well. And this is the bifurcation view. So bifurcation view, you have to see a figure of 8 or at least no major stunts across the bifurcation. To conclude, imaging is extremely important. And IVL, believe you me, is a lifesaver in most of the times when you get into trouble. And this can be used much more easier than the other modalities which we are using. Thank you.
Wonderful case, Mahesh. Yeah. Sandeep?
No, it's amazing case. No, I think you showed a very nice case. I think you also mentioned you're right. There are so many IVLs are coming, in the market, but the data is so clear with the shock IVL, with all the data coming out, and I agree with you that it's one of the best IVLs we have.
Great.
Mahesh, yeah, let me ask you. This case had an eccentric lump of calcium there, and it was perhaps a nodular calcium. So, what would be in your mind if the balloon-based technology is deliverable? You will go by IVL, but then you would know only when you deliver it. So, or would you consider orbital in this case? What was your thoughts in the beginning?
The JAC paper, the JACC's last year's most well-read paper, I am also an author. It says it is a very good modality for eccentric nodular calcium IVL. Okay. The difference, I will just tell you the difference in the approach. Suppose this is the nodular calcium. Everybody does is keep the balloon here, inflate it to 4 atmospheres and burst. The emitters are going to hit here and hit here. I do it differently. I go from here, keep the balloon climbing up this slope of the nodule.
Billowing.
Finish there first. Then go across. Finish there first. then go down and then finish it. Don't keep it in one place and give 18 knot. So, and if some people do 6 atmospheres, thinking that 6 atmospheres will do better job. It doesn't. If the smaller the atmosphere, 3, 4 is ideal. The balloon should be slightly, it should be expanded. It should not be tumescent. So one set of emitters here, one set on top, one set below, and you can be rest assured that in 90% of the cases in our study, we had successful destruction of the same. Orbital is definitely a very good alternative. The problem is if it is an orbital, or even my second choice in these cases are ELCA actually. I use ELCA with diluted contrast for heavily calcified lesions. That also works wonders. So orbital is not my go-to thing as of now. My strategy is if balloon can cross straight away IVL, no balloon, then I'll do a rota, get the track for the balloon, open out the slightly with a 2.5 NC balloon, then use an IVL, and then if the IVL, post IVL, there is not good adequate expansion as you had said using the NC balloon, then image and go for a cutting balloon or go for a OPNNC. This is a strategy I'm using as of now. Works in most of the cases. Especially important because if you have no calcium on one side and there is a nodule on the other side or significant calcium on the other side, don't aim for perfection. Try and get good MSAs.
Can I invite some expert comments from Dr. Suyas Started and Dr. Gaurav Singh? Dr. Gaurav Singh and Dr. Suyas? Sandeep
Hello.
and Mahesh, yeah, please, Dr.
Hello.
Suyas, yes.
Yes, sir. I think very nice cases presented by all the faculties. I just have a simple doubt, not comment. Many a times we are using IVL, but still after giving maybe 40 to 50, 60 waves at single point, we are not able to achieve that the waste is not breaking out. So now we are left with somewhat same amount of 40, 50 pulses. So whether we should aim to open that single point or because we are having calcium at other points also. So what will you suggest? Which place we should be focusing more for IVL? Because in our setup, we only can get one IVL balloon. That is
Okay.
120
I think that's
pulses.
a good point. So if you have only one IVL available and if it's a long lesion, concentric, ignore it. You can use a cutting balloon or an NC, high pressure NC balloon. Focus on an eccentric calcium. If you got, let's say, 120 pulse, if you got two lesion, use 60 each. Okay. And then take a high pressure NC balloon and try to open it. Okay. Second thing, as I said to you, like in the last few minutes we were discussing, if there's a good wire bias and if you can use rota in your center, in the sense, if the cost allows rota and tripsy, then use rota and then use a shockwave. If you can't use a rota, then you use the 60 pulse, take a high pressure NC and it will expand. Nodule is a different beast. Nodule, a lot of the videos still don't know what's the optimal treatment for nodule, especially non-eruptive. We don't know how to treat it. A lot of the time it's...
So we had
if
a
you got
paper,
a...
we had a paper on 78 nodules that we published. That is a paper I was referring to in JAC. That had 85% success rate with nodules as evidenced by a crack in the base on OCT, or B, nice response to post IVL NC balloon expansion.
You see, that's okay now, but what my concern is the long term. See, for
That is
example,
why
I've treated...
eruptive nodule long term, very bad, whatever you do.
Yeah.
But nodular calcium, we can get away with IVL.
With the nodular calcium, if you achieve a MSA of 5 or more, great.
Yes.
But if you can't achieve 5 or more, if they do come back, it's become very difficult with the stent already there.
They will come back. So if you not achieve 5 or more, you're not finished. The funda in calcified lesion is if you have not prepared your base properly, you do a stent on top of an unprepared base, you have lost the battle.
So better not to stent. That's what I say. If you better not to stent, you DCB or something, leave it.
Yes.
I would like to add it here about the question of Dr. Suyas. ask that what we should do whenever we are not getting up with the 60 or 80 pulse and we have the eccentric calcium already there. So as I can say that theoretically as well as practically what we experience, if we did the 40 or 60 pulse in a place where we have the eccentric calcium and it's not giving up, I think it's a better approach to go with the rota or orbital first and then use your whatever you left with the 30 or 40 or 60 pulse.
I agree.
It may be better option or maybe give the better expansion. In comparison, you are lost all your pulses in the same place and then you again require rota or orbital and now your balloon exhausted, so other place you could not use it. So I think it may be a better option for you if it's not going as Dr. Sandeep rightly pointed out. If you could not crack it in the 60 or 80, it's only 10% more chances to crack it by the other 60 or 80.
Oh,
Okay,
thank you.
perfect.
Dr. Mahesh,
Yes, sir.
on the Bali trial, there was a perforation in the in the IVL arm. Seldom that we see any kind of perforations with the IVL. So was it due to about 31%? I understood that they had a rotablation. So that means that it had a little more significant calcium than on the balloon-based arm. So
Yeah.
was that a confounding factor
It is
for
it is
the
basically
perforation?
eccentric calcium which leads to perforation. They never said the perforation was during IVL. They just said it perforated. Probably post IVL NC balloon dilatation or stent being overexpanded, it may have perforated. Not necessarily that it perforated during the IVL. IVL balloon, I have never had a perforation so far. I've only had balloon after the when we go for a perfection post stent deployment is the times I've had my perforations.
One small doubt or question I want to ask you all eminent faculties here. As Dr. Suya's question continues, and that if we are not getting up with the 40, 60 or 80 pulses, can we use IVL balloon on higher pressure? I can say there's a 6 mm Hg and inflate it. And what your experience about the rupture of balloon in these cases? Is there an air has any role in the rupture, more rupture with if we have air in the balloon?
That's
Yeah, if you got
absolutely
air
wrong.
in the balloon, oh, sorry, go ahead.
Yeah,
Go ahead,
absolutely
Mahesh.
wrong concept. That is a concept that destroys the concept of IVL. Please don't overinflate. It doesn't work. It just doesn't work that way. If you feel that your balloon has got what I do in extremely calcified lesions, which I have dilated with a 2 mm balloon, if I feel that the calcium is too much, I will always pass a guide liner through and get the IVL balloon through the guide liner so that I don't rupture it. So this concept of that is exactly what I was trying to stress. The concept of thinking that if you do an 8 atmosphere pressure and then you deliver, it's going to work. It is not going to work.
I agree. I think if you take 1-to-1 balloon sizing, you don't need to go beyond 5 atmosphere is the maximum. And so, yeah, I agree with you. And then, yes, you're right. Sometimes it has ruptured for me as well, a balloon, because of the calcium spicules. As you crack, it can rupture the balloon. The most important is that your second operator should not press the shock, the pulse when the balloon is deflated. So you have to ensure the balloon's fully up before you deliver the shock, because if you deliver the shock with still balloon's not fully inflated, it can rupture.
I think there's a question by Dr. Suyas. Is the perforation post-IVL more common after an aggressive NC balloon dilatation compared to post-rota NC? And what to
No,
do
the other way
to
around.
protect it?
So if I see a post rota, you get high perforation, whereas with IVL you get less.
Yeah, the
Actually,
Bali
post
also showed that.
any or calcium modification devices in which we did more injury to our vessels, rupture chances or complication chances higher. So I can say that for the IVL, it is a minimum chances of any post dilation injury because it's causing less injury to our vessels. Rota definitely have the higher chances of the perforation
Yeah.
or the dissections.
Totally agree.
Shockwave, what I do is I probably use a cutting Wolverine balloon or sometimes an open balloon, and then I use IVL rather than directly using IVL or having a higher threshold for orbital.
You have rich patients, man.
No, I'm saying using a Wolverine, especially sir, even the scoring balloons have got a high reusability. Scoring balloons, if you look at it, probably you can use multiple times as compared to and even on open. So such
If you're
pictures.
committed on IVL, you always go ahead with it. If money was not a criteria, I would do IVL on all my calcium patients, whatever they have. Since money is a major criteria, I go step by step and select my patients.
Yes.
So if my IVL doesn't work, then I will go for a cutting balloon, or I will go for a OPN balloon, and then see if I can strategize. And if I can get a good MSA, then I leave it at that. If I don't get a good MSA, I'll do a DCB and come out if it's possible. Avoid stenting if you have not prepared the bed well.
That's a great comment, because almost all patients with calcium will have all forms of calcifications in the vessel. It'll have concentric calcium, eccentric calcium, node lock calcium across the length of the calcified vessel. So there's one tool that can be applicable to modify optimally all forms of calcium that a person or the vessel segment involved has. Mahesh, one more question before we go to the next case. I know that I'm delaying with too much of discussion. For effective delivery, we need a 1:1 apposition and measurement of the balloon to the vessel ratio. So it applies to the IVL also. So when in a distal left main with significant variability in the proximal as well as the distal, as we move from, how do you measure to the circumflex and the left main? If there is involvement in the left main, also extending calcium, and the circumflex is 3.5 and the left main is 4, left main is 5.0. Would one balloon would suffice in that case, because that balloon would be floating in the left main, and it would hardly deliver any impactful contact with the vessel?
So it depends on which side I'm more stressed on, whether it is the ostium of the circumflex or it is a left main. If it is the ostium of the circumflex which is giving me trouble, I'll go with the 3.5 and then do it there and at least open out that part. Left main, we'll modify with something else, a cutting balloon or an NC balloon. If it is the left main that is heavily calcified and the ostium is one of the side prodigies that is existing there, I will take the largest balloon possible, do the left main well, get into the circumflex, inflate it to about 3 atmospheres. I will not inflate it to 4 or 5 atmospheres, 6 atmospheres, and gently do off the circumflex ostium without causing too much of damage.
Yeah, I
What's your
think
comment,
that's a
Sandeep?
good point. That's a good point. I think you can oversize IVL balloon, no problem. In fact, you say it's sometimes you have to oversize. The cushioning effect happens. So if that case, I take a 4-0, do the left main, push it down. With the aero, you can do it now, especially with the aero when you get it in, and then you can do it.
Yeah, I think that's very relevant, because the barotrauma is much, much less in IVL, because you go only to 4 atmospheres. It is a sonic wave, which is pulsatile delivery occurs. So thanks so much for such exciting discussion. Let me invite
Guys, I need
Dr.
to
Anupam.
sorry, Manoj, I need to leave because I got to call to take.
I understand that.
So you
Yeah,
guys
thanks
carry
so
on.
much for your presence. Yeah, thank you.
Thank you so much. Thank
Great.
you, everyone. Bye.
Let me invite Anupam Jena on his case of synergy in stone. Anupam? Is Anupam there? Has he logged in?
He's not there. He's not there.
There till now.
He was there, actually, yeah.
Maybe you can invite the other next speaker, sir.
Yeah, so then we'll move on to Dr. Gunjan Shah on rototripsy in a calcified ostial LED lesion.
Good evening, everyone. Are my slides visible?
Just appearing.
Yes.
Yeah.
So today I'll be discussing a case of 75-year-old diabetic hypertensive female, which presented to us with a one-day history of typical angina. Troponin was positive outside. ECG had anterior STT changes. Echo showed normal LV function. CAG showed calcified triple vessel disease with distal left main 50% disease. So this is the angiogram of the patient. Alveocaudal view showing that the ostial LED is critically stenosed and the OM is proximally completely chronic total occlusion. The LED had a long lesion up to the mid part, and there was calcium, eccentric calcium at the confluence and in the left main extending into the ostium of the LED. So my plan was to do imaging first and then decide whether I would like to do rota or not, but I was definitely going to use IVL. So target vessel was LED. The plan was to do a standing from LMCA to LED. It was a Medina 110 lesion. The red flags were elderly patient, heavily calcified bifurcation, and calcified nodule or eccentric calcium at LMCA confluence. The plan was to do detailed lesion assessment, proper lesion preparation, and balancing risk benefit ratio since it was an elderly female. So I took a 7F sheet through radial and I did imaging upfront, which as you can see, the distal reference LED was around 2.9 millimeter. The mid LED MLA was 2.75 millimeter with almost 180-degree calcium. The ostial LED has 2.9 millimeter square with almost 360 degrees calcium, except the part where the circumflex was rising, and the LMC diameter was 5.2 millimeter. So this was the IVS image. I'll just fast forward to the point of LED ostium. So this was the proximal LED lesion, and now the ostium with almost 270-degree calcium extending into the distal LMCA, which was concentric calcium. So eccentric as well as concentric calcium. I know that the length was not too long. It was probably 6 to 8 millimeter of calcium plate. But it was a part of the vessel where you would not accept a lesser MSA for future MACE events. So I did rota first from LM to LED. Since the IVS showed that there was kind of favorable wire bias, so I decided to do rota first. Further, I dilated it with 2.5 millimeter balloon, and then as per IVS sizing, I decided to use a 3.5 into 12 millimeter IVL balloon. So this was the expansion of the IVL balloon, which was pretty good. Not and since after the mid LED was 3 millimeter, and I started doing IVL from mid LED, which so the 3.5 millimeter balloon was more than 1:1 ratio for the vessel. So I guess because of that I dissected mid LED, and so I did not do post IVL imaging, and I immediately decided to stent it first. Right. Stented mid LED with proximal to mid LED with 3 into 32 millimeter stent and ostial LED with 4 into 21 millimeter stent. So pot was done with 5.0 balloon, and mid to distal stent was optimized with 3 millimeter NC balloon, and proximal stent was dilated with 4 millimeter. Final kissing balloon dilatation was done with 4 millimeter balloon in LED and 3 millimeter balloon in LCX. So this is the IVAS run post stenting after dilatation. Ostial LED MSA was 8.3 millimeter square, which was good for me. Distal LMCA area was 10 millimeter square, and proximal LMCA was around 14 millimeter square. The IVAS run is pretty long. There was another IVAS run which I had taken after rota, which showed crack at two places near confluence and on ostial LED. Even though you can see that the wire is biased towards eccentric calcium. There was good expansion of ostial LED. And this was the final result. Obviously, the patient was advised CABG first, but because of advanced age, the relatives and the patient was not willing. So this is the algorithm for modification of calcified coronary lesions, which I am not going to go into detail about. So the take-home message is you can never over prepare for calcium modification. You can always under prepare or prepare just the right amount for calcium modification, but never over prepare. The proper preparation of the lesion is important for optimum stent expansion and thus reducing further maze. Rotablation is the go-to modality of the choice in our setup for balloon non-crossable lesion, as ALCA is not available and is little costly. And this was not the case for balloon non-crossable lesion. Patiently cutting with rotablation is important to cut the calcified arc, prevent perforation, and prevent stuck burr. Calcium, and the most important thing is what I feel is calcium modification is not just a one-man army job. So collective use of more than one modality is always better, as we used rotaripsy in this case. Thank you.
Dr. Amit and Mahesh, your comments.
Very nicely done. Demonstrated, especially the rotablation part, and then after that doing so rotablation and IVL, as Dr. Mahesh with other team members were contemplating, work synergistically with each other, and very good MSA in the end you got. So very good result.
Thank you.
There is no requirement to image every time. You image in the initial part to make sure that you have done a good job, what you're going to do. And then at the end of the day, you image again to see that you have done a good job. In between, you image only if you feel that you have not done a good job in preparation of the bed. So you're having a dissection, forget imaging. Straight away, you don't have to. You have dissected means you couldn't open it out any better.
Yes,
so
sir.
there's no requirement for imaging at that stage. So imaging is required initially to assess and strategize what is going to be a strategy, where is going to be rota, where is going to be orbital, where is going to be IVL, and what are the sizes you intend to achieve. After that it is done, then you image only if you have a problem with your bed preparation, or at the end when everything is done, just to go a good case presentation to Dr. Manoj saying that I've done a good job.
Yes, sir.
Let's say, so for example, let's say if we develop an intramural hematoma post dilatation with an NC balloon, and with an IBIS, obviously with an IMH, you will not get a good MSA. So what would be the strategy then?
Cutting balloon.
In such cases?
That's where Wolverine scores heavily. Make sure that you cross hematoma area, dilate, it cuts, it drains hematoma, go ahead and do the stenting.
If the
I think
patient
it's
is
similar to the spontaneous coronary artery dissection. So it drains, it causes cuts in the intima and then allows it to drain.
But let's say if angiographically we don't see the IMH, we see only on IVUS, and the patient is totally stable.
MSA. What is
MSA
your MSA? The MSA is good. Make sure your stent distal edge is beyond the IMH area. If you put it into the IMH is going to spread as you just cross your stent beyond that, inflate, it'll stay.
So the contrast stains in the vessel wall, and there is a distinct IMH. That is where perhaps you can consider scoring or cutting balloon. But cutting balloon has better job because it gives precise focus force on that, rather than again in the scoring balloon the wires may lie somewhere else, and there could be uneven expansion. The wires may splay. So we do not know. The cutting balloon, the microtomes do not change its position. So we'll get a precise cutting. Yeah. So I think that's a wonderful presentation from Gunjan Shah. I know that we'll slowly get the Aero also, the Aero version. It's much more deliverable. It's got a closer, a very, very short crossing profile. It also has hydrophilic coating to allow it to deliver. So once this technology becomes more deliverable, this will be an easier tool for calcium management. And that is another challenge that is become overcome with the Aero version, which is now available in European countries. Again, another modification was that the two emitters are equidistant from the two balloon markers. Previously, in the current versions, the balloon markers are a little eccentrically placed and more closer to the proximal marker. But I'm not sure what is the concept behind that repositioning of the emitters would do in any better way. Mahesh, you have any suggestions why the emitters are eccentrically placed and now the newer version of the Aero has 3 millimeters on either side from the balloon markers?
Yeah, that is news to me also. I have not read at all. I'll read and get back to you on this. No experience.
Another
Bosraj,
doubt I had was, sir, what is your experience with using IVL as a rescue thing after stenting, where you have not achieved a good, you felt that the pre-NC dilatation was good enough, but you didn't achieve a good area. Like I had a case once, the LED, mid LED was around 3 millimeter, and the distal reference area post stenting was around 6.2. But the mid LED MSA was around 4.2, 4.3, which was not looking good. So I did IVL, and the area I achieved was around 5.6 after using IVL post stenting. So what is your experience of?
I totally agree with you. There is a study from Dr. Ziad Ali which says that post stenting IVL does not cause much of a disruption in the polymer or the drug these things or in the drug dispersal, even if you do a post IVL post stenting. But again, the bottom line I have always repeatedly says that if you have not prepared the bed well, if you do an NC balloon dilatation, and if in two orthogonal views your NC balloon has not come up, and then if you are in a hurry to go and put in a stent, you will pay a heavy price of 2.5 lakhs. You'll have to put in your IVL, expand it, and then dilate it to the NC balloon. It works. Once inside the stent, no point of using a cutting balloon, you miss the bus.
Yes, sir. Okay.
Those scenarios generally happen when you have not used the IVL at the baseline and not assessed the calcium, and then you have gone ahead with the stent, and the stent doesn't expand. So it is a poor understanding about the lesion characteristics and the calcium distribution and the severity of the calcium that makes the stent less suboptimally expanding. So obviously, if you land up with such a scenario, IVL is definitely a choice. And there are multiple studies. One is by Siad Ali, the other one is from China, which is the Dragon study, which definitely shows there's a significant enhancement of the MSA with the use of IVL technology post for suboptimal stent dilatation or expansion.
And another doubt I had was, since the LED is always tapering, and say you have a calcified lesion from proximal to mid LED, which is around 3 to 3.5 millimeter from mid to proximal part. So is it better to use a 3.5 millimeter IVL balloon and use it at 2 or 3 atmosphere in mid LED and 4 atmosphere in proximal LED? Or is it better to use a 3 millimeter IVL balloon and then inflate it at 4 atmosphere in mid LED and 6 or 8 atmosphere in proximal LED?
IVL is a very forgiving balloon. Go for higher size. Kuch nahi hoga. Only thing is that don't go and expand it there to 8 atmospheres, 10 atmospheres. Just go 4 atmospheres as advised. Do distally, come back, and when you come back into the main the area which you are comfortable with, go in slightly higher atmospheres. That is my opinion, Dr. Manoj.
Yeah, I think that's not a balloon for dilatation. It's a balloon just to snugly hug the vessel lumen and vessel apposition and deliver its technology of sonic wave. So a 0.5 mm upsizing does not matter. Another way of choosing is also look at the distribution of the calcium. The distribution of calcium is in a larger segment of 4 You choose that vessel because distally you can always do a little low pressure and then deliver it, and the effective calcium modification delivery can be done in the vessel on which it is sized 1:1.
Yeah, thank you,
Many
sir.
times use bigger size IVL balloon, there is some rhythm change seen on this monitor. Some ectopic rhythms start coming. So is it an indicator that we are using oversized balloon and we should avoid it, or we can continue doing IVL even with that? If I had one case, so I just want.
Yeah, Suresh, if you're driving, switch off the camera so you can concentrate on driving. We'll hear you. So the what I was saying was, you're talking about the shock topics, or you're talking about any other ectopics?
Sir, in my case, actually, what I did was I similarly, as Gunjan said, I use a 3.5 balloon, and the distal vessel was somewhat 2.75. So suddenly, as I started doing IVL, the rhythm start changing, and it was like the AIVR rhythm that we usually see.
So that is probably the shock topic induced arrhythmia that can happen, whatever size of the balloon that is happened. It just so happened that your shock topic went and hit on the R on T and created a C. If it is hemodynamically stable, leave it alone. If it is hemodynamically unstable, shock.
So patient actually was stable and the complexes became widened. Then when I stopped the IVL of distal part and started doing in proximal LAD, the rhythm was okay in that part. So I thought maybe because we are oversizing the
Not
balloon
because
in
you're
the
oversizing, but your shock topics got conducted into the system. Doesn't matter. As long as you're hemodynamically stable, continue with your job. Just wait for, give him some breathing time so that the vessel flow is regained. Once, then don't immediately go for the next round of this thing. Wait for a few seconds or few minutes. Let the flow go in. Let the artery and the heart stabilize. Then you go ahead with the rest of the case.
Yeah, the electrical energy often causes shock ectopics if the patient's rhythm is less than 60, because you deliver the shock pulses at 1 per second. So if the heart rate is less than 60, it's likely that there is a more possibility of capturing of the myocardium. Otherwise, it will just be a spike and it may not capture. And very rarely and seldom it causes R on T because it is for a very short period. It's not a sustained.
Agreed.
Do we have Gunjan Shah on our panel, or is he still logged on?
Gunjan Shah has just finished his talk.
Yes, sir.
No, I'm sorry. Dr. Anupam Jena.
Jena.
So, sir, I just contacted Dr. Anupam. He has a primary case, sir. So he
So
has to
anybody
leave
is
for the
there?
hospital.
Anybody to present?
No, sir. All
Then we
presentations
can
are
call
done.
it a day, Manoj. You've done so well. You've timed your long discussion so well that we ended up on time with two people talking.
Yeah, that's
That's the way
true.
it should be.
Thank you. Thank you. Thank you for
Excellent
wonderful
discussion.
cases and
Manoj,
thank you
very well
for
conducted.
exciting discussions. Yeah.
Thank you. Thank you, sir. Thank you. We learned a lot.
Thank you, everyone. Good night.
Thank you
Good
so
night.
much,
Good
sir,
night.
for your valuable time. Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you, Vishal. सुप्रिया एंड कर दो आप मीटिंग